Okay, our next presentation is from Anthony Arnold, who's the Director of Cancer Services at Illawarra Shoalhaven. And he's talking about Oncology Information System web-based access portal development.
So the session is themed using information to improve outcomes, but you can't use the information if you can't get to it. So my talk is really about a project that was developed to improve the access to the clinical information systems for our clinicians. The aim of this project was to develop a reliable and secure access portal to our patient care applications. Particularly in a mobile environment with our staff working across 3 physical locations in our local health district. So we were trying to improve clinician accessibility, facilitate improved patient management by simply giving them access to the clinical information system so they could build a picture about the patient or the situation, to give them a more efficient support in terms of their clinical decisions. So in terms of the nature of the problem, in the current healthcare environment, it demands real-time access to patient informations and patient information systems for the clinicians, for them to make appropriate informed decisions about the situation. Those clinical information systems really support the decisions that our staff are trying to make. Historical access, in terms of remote access to clinical information systems in a health district environment, is via a traditional virtual private network environment, and it requires security tokens and pass-throughs. It's often unintuitive, time-consuming, causing frustration. And look, at the end of the day, in our situation, it definitely resulted in a reluctance to even try and use it. One major drawback of our virtual private network access system at the time was that once connected, clinicians were physically cut off from their own private network. So they may have been in a private practice in their network environment with their clinical notes. When they connected to the cancer system to perhaps try and prescribe some chemotherapy, they were disconnected from their local environment. A really big detraction. So with the expansion of our cancer services across the Illawarra Shoalhaven, and particularly the introduction of the new Shoalhaven Cancer Care Centre, there was increasing feedback regarding problems, specifically around time to access the systems, instability once being connected, often being randomly disconnected, and a restriction on devices and the physical devices you could use to get into the clinical information systems. And as I said before, there was that major undesirable consequence that once connected, you were physically cut off from your private network wherever you were. And that was particularly a big issue for us with many partial FTE practitioners working in multiple locations across the district. So after conducting months' worth of site visits to the private practice and remote locations, it became explicitly clear that the problems weren't able to be overcome within the current ICT-provided virtual private network arrangement at the local health district. And definitely an alternate solution was necessary to try and improve clinician access to our oncology information system. Via a VPN tag, poor reliability like I spoke about, buggy environment, and unpredictable errors. Not the type of environment you want to be providing your clinicians when they're trying to access your clinical systems. So an opportunity existed to purchase a add-on gateway to our oncology information system platform that would provide the ability for us to connect remote users, adhering to the key foundations in an ICT world of access, security and usability. We were successful in obtaining a quality improvement grant from the New South Wales Cancer Institute towards the project. So following that, a small team was assembled, and that importantly consisted of medical oncology staff, radiation oncology staff, medical imaging staff, our IT IT experts, my IT nerd friends, and the Citrix vendor themselves. They were the provider of this hardware. So the gateway, as it's called, was installed within the IT demilitarised zone. I can't really describe to you too much about that because I'm a radiation therapist, but I'm going to do my best in a minute. And the initial pilot began within Cancer Services. So what you can see here is a complex diagram. Is that? It's not going to work real well. So you have many users on the outside trying to get access to your clinical information systems, which live over here in a world of servers and complex hardware. What we have installed is an access gateway, and it essentially lives in what I like to describe as two huge red walls here that you can't climb over, no matter how hard you try, unless you have the right security and the right access. So what you can see from this diagram is that no matter what device you're coming in from, whether I try and get in now from this device here, I cannot get directly to the servers and the information system unless I'm granted access through this portal. That's sort of my way of explaining that diagram. My IT friends would describe it very differently. So just to show you an example of the interface, it's built depending on who logs in as to what applications and what privileges and access you will see. Of course, our IT guy here has access to every system at the moment that we are running through this interface. As I said, initially it was for cancer systems, but it's been expanded to a whole host of other clinical information systems because we found they were facing the same problem. So early indications were positive post putting the pilot in place, and it resulted in a very prompt expansion to other areas immediately, to include our district EMR, our district PACS system, particularly to improve access for our remote radiology reporting. We were having huge problems there with the guys trying to get in and report on radiology images in the context of the patient presenting and the patient's problems, most of which were contained in the EMR. So they're trying to build information and a picture from two clinical systems which were disconnected from one another until they could use this interface. So very quickly after putting the pilot in, our IT guys were the toast of the town, and most visitors to Cancer Centre for a period of time were to see the IT guys, not to have anything to do with anybody else. So to try and get some sort of analysis of the pilot, we ran a user survey. And what this shows you, that while predominantly the users were from a cancer services background, the system was covering all areas across the health district, from radiology, neurology, theatres, surgery, and even subsequently post that, we've even got some of the hospital executive dabbling in the system and the access. This slide is here just to show you that the access gateway was successfully running across two separate local health districts. So we had staff operating not only at remote locations within the Illawarra Shoalhaven, but we were providing access for people working in southeast Sydney. So this chart shows you a split across users and professional groups. Again, whilst intended, the majority of access was for our medical staff, for them to be able to remotely prescribe and modify chemotherapy protocols within the system. But you can see here the use was split not only across the medical staff, we've got nursing staff, physics staff, radiation therapists, management and admin teams, and others. So the user survey focused on a couple of key areas around access, usability, patient safety. Thanks. And you can see here that results were very positive in terms of a perceived improvement in patient safety. It was allowing people to work more efficiently and allowing them to save time, chasing results, pulling together the information about the patient. And I think probably best described here by one of the radiologists who very quickly fell in love with the system and became a strong advocate. So this was a typical situation for our radiology guys trying to report on a situation and provide advice in a radiology report context. By being able to easily access all the information from the various clinical information systems, they could get a result and manage the patient appropriately. Reliability was a key focus for us. As I touched on earlier, the reliability of the original system was really poor, to the point where people gave up and didn't even try and access. So reliability was hugely improved. Somehow we've even managed to provide the answer to some medical staff prayers. So timely access equals timely treatment. I think that's the key message there. In terms of multidisciplinary team and meeting operation, again, very, very positive feedback around the system. It streamlines the viewing of external images, whether they be from our radiology within the district or whether they be from private radiology providers outside of the district. All of the information is one place, easy to access. So one of the most relevant indicators of success was the very fast expansion of the system beyond cancer services to other areas. It's now reaching pharmacy, the inpatient wards. Wollongong Hospital bed managers are using it to improve their ability to manage beds across the hospital system. And probably the thing that gives me the great pleasure is to see our Chief Executive, who retires today after an extensive career in the health system and over 30 years in the Illawarra Shoalhaven. But to see Sue and her executives sitting at executive meetings using the Cancer Gateway to access their meeting papers, I think is a huge, huge success. In terms of sustaining change, this is a sustainable enterprise level solution. It isn't a local invention. Citrix are a well-established information technology service provider. They're already heavily integrated into New South Wales, and the success of this pilot, importantly, is at present transforming the method of remote access for all users in the Illawarra, Shoalhaven and South East Sydney local health districts. This system is being implemented for all users, to all systems. This graph demonstrates, again, sustainability. It shows a steady growth in user transfers over time, and the vertical drop you can see here was at January 2014. That reflects a system reboot that was required. So we've had one period of downtime where the system needed to be rebooted. A single reboot over 12 months, I think, shows quite a good level of reliability. This is very transferable to all other systems and all other LHDs. It provides every service in New South Wales a method of increasing mobility and accessing their critical clinical information systems. The benefits in the way that we were providing care became immediately apparent to other departments, and they were jumping at the door to try and have their systems incorporated. As I said, information services for the district have adopted this solution for their enterprise level remote access. And any system that is deployed by Citrix could be published to that web interface. This aligns with both strategic directions of the New South Wales State Health Plan and the eHealth Blueprint for New South Wales. It integrates care and ensures that technology is at the forefront of patient care. The project has promoted core values in operation. It respected clinicians' input and came up with a solution that met the needs of everybody involved. Just a special thank you to a range of people involved there, without which we wouldn't have got it off the ground. And I'll finish with a poster that I've had laminated and put on the wall of my office. So I'll finish up there. Thank you.